Hello everyone. So we have a 34-year-old woman who come to emergency room because of right lower leg swelling, redness and pain. Well, she has a her mother has a history of pulmonary embolism. Vitals are normal and examination shows tenderness on palpation to the right calf. Compressive ultrasonography shows a deep vein thrombosis of the right leg. Well, she has elevated plasma homocysteine level. She started on heparin and warfarin therapy. Now, what other additional therapy is indicated in this particular patient? The answer is pyridoxine is indicated. Why this? Let's learn in more detail. The patient has deep vein thrombosis in the setting of increased homocysteine levels. Homocysteine is a highly reactive amino acid. And the increased level predisposed to venous thrombosis as well as atherosclerosis. That means dangerous for both arterial and venous system. And this due to a combination of, it can cause direct vascular damage, both artery and vein. It can activate clotting mechanism also and inhibition of antithrombotic pathway. It means you can say it's a type of increased level, it is a type of prothrombotic. So the patient DBT treatment should include attempt to correct her homocysteine level. Now let's read more basic concept about homocysteine. Without understanding of the basic, you will not understand why the answer is B6. Homocysteine can be metabolized to cysteine or methylated to form methionine. So these are the two end products that can happen from homocysteine. In either of these pathways disrupted by enzyme or cofactor deficiency, the homocysteine level will be elevated. Well, homocysteine to cysteine pathway is catalyzed by cystathionine Beta-synthase, in short we write CBS, and the cofactor is B6. So now, and homocysteine to methionine pathway is catalyzed by methyltransferase, methylenetetrahydrofolate, reductase and methionine synthase with folate and cobalamin as essential cofactors. Okay. Well, if you look into same, this homocysteine getting converted into cysteine and we need B6, and homocysteine getting converted into methionine, we need B12 and folic acid. Okay. So B6 and B12 and folic acid. Now, independent of underlying cause, homocysteine level can be normalized by addition of B6 and folate. B12 should be added if B12 deficiency is documented. B12 treatment will correct homocysteine level. Okay, so now we can see there is the role of B6 and B12. Well, so we need any of these. If you look into the options, now other options, clopidogrel, they inhibit platelet aggregation. Now, what's the mechanism of action of these drugs? Write down the answer of this question. How these two drugs are going to act. They block ADP receptor on platelet. So they are antiplatelet, but they have nothing to do with homocysteine metabolism. So this option ruled out. Clopidogrel is used in the treatment of arterial thrombosis like MI stroke, but not used in the treatment of venous thrombosis. Vitamin E is an antioxidant act to protect cell membrane from free radical damage. It has got no effect on homocysteine metabolism, so it is not the right answer. But again, I have a question for you. Write down the answer. What are the important effects of vitamin E deficiency? Various, whatever, in the whole body. They can disturb spinocerebellar. The vitamin E deficiency can lead to ataxic gait. They can also lead to posterior column dysfunction, which can lead to loss of position vibration sensation. Peripheral neuropathy can lead to areflexia. It can lead to ophthalmoplegia, skeletal myopathy, pigmented retinopathy. It can lead to hemolytic anemia, acanthocytosis, and thrombocytosis. So you can see there is involvement of the neurology in the blood also, in the muscles also. Let's look into other option. Each one is used in oral contraceptive pills and hormone replacement therapy. And there's an increased risk of thromboembolism. And moreover, it is not going to reduce homocysteine level. So this option is totally ruled out. Simvastatin reduces LDL. It is HMG coenzyme A reductase. It is not used in the treatment of deep vein thrombosis. The golden line to remember, B6, folic acid and B12 are involved in the metabolism of homocysteine. B6 lower homocysteine level by acting as a cofactor for enzyme cystathionine beta-synthase, which metabolizes homocysteine to cystathionine. Homocysteine to methionine pathway is catalyzed by methylene tetrahydrofolate reductase and methionine synthase. For this, we need folate and B12 and essential cofactors. Okay. Hello everyone. So we have a 25-year-old lady. She comes to you with 6 weeks history of dyspnea and fatigue. She has no other medical problem. There's no family history of blood disorder or asthma. BP is normal and other vitals are also normal. Examination shows pallor, scleral icterus and mild jaundice and splenomegaly. The lab reports hematocrit is definitely low. And if you look, the total bilirubin is increased. It is direct is only 1.4 out of the 7 total. That means primarily there is indirect. Indirect bilirubin is raised. And you can see the LDH level is also increased. And rest of the retic count is increased. Rest all the reports are within normal reports. Okay. Well, the peripheral blood smear shows spherocyte without central pallor. Coombs test is positive. I think this is one of the single most important line in the whole question, which is going to give you a clue, which is a clue, and you can answer this question in just 1 second. What is that I'm going to discuss in the next slide? Most likely diagnosis, well, if you look into all these options carefully, which you have seen, autoimmune hemolytic anemia is the answer. Why? Just remember the golden line to remember. If you get Coombs test is positive in any condition, any question, it is a autoimmune process. But this will be positive only when autoimmune phenomena is there. Now, I said you can answer this question in 1 second only. How come? Look into this question once again. This is autoimmune, that is the answer. If you look into other G6PD deficiencies, hereditary spherocytosis, PNH and sickle cell, all these are non-autoimmune. So we just learned that Coombs test will be positive only in autoimmune. So without anything, this is the answer. The question, and that is universal true for any question. So golden line to remember, Coombs test is positive. In this case is AIEHA. Otherwise, in any condition, Coombs test positive means it is an autoimmune process. With this background, we already have answered the question, but definitely we'll be discussing every option. So let's talk more about AIHA, that is autoimmune hemolytic anemia, basic concept. Then it will really enhance our knowledge. So what are the etiology? We have two types of warm autoantibodies and cold autoantibodies. Causes of warm autoantibodies induce AIHA, autoimmune disease like SLE, drug like penicillin, amoxicillin, alpha-methyl dopa, lymphoproliferative disorders. Etiology of cold AIHA infection like mycoplasma pneumonia, it is universal question. So important question. Infectious mononucleosis. These patients of AIH, they usually have normocytic anemia, hemolysis, reticulocyte count is increased. This is there in our case also, 8%. Jaundice, total bilirubin is 7 milligram per percent. And indirect is mainly because direct bilirubin is only 1.4 out of 7. So that means there is elevation of indirect that I discussed. Increased LDH, that is the feature of all hemolytic anemias. Feature of hemolytic anemias, any hemolytic anemia. Now in these patients, splenomegaly is a feature. This is due to erythrocyte entrapment. Commonly developed. Examination shows pallor, scleral icter and splenomegaly. That is there in our patient also. And bone marrow will show reticulocytosis, 8% is there, that really support the diagnosis. Now, how they really present to us? A symptom, warm agglutinin AIHA, it could be no symptom to life-threatening anemia. Hemolysis occur in room temperature. In contrast, in AIHA, symptom of anemia will be there. There may be libido reticularis and peripheral cyanosis with cold exposure. So point to be noted, this happen in extreme cold, like 0 to 5 degree or maybe below also. Okay, and that disappear with warming. So it will. That's why it is known as cold agglutinin AIHA. So now look into the libido reticularis. The skin, you can see a lace-like pattern is there. This is a classical feature of libido reticularis. Then this peripheral cyanosis, you can see all are due to exposure to cold. Now what you see in peripheral blood film in AIHA? Spherocyte. This is the one that you got to understand. Normally when we talk about spherocytosis, we always think about hereditary spherocytosis. So there can be microspherocyte, that means the size of RBC may be even smaller than. Increased number of polychromatophil cell like reticulocyte. Now spherocyte in PBF are seen in hereditary spherocytosis and AIHA. Many students are not aware that this spherocyte are also seen in AIHA. Okay, well, definitely that I told you this, in this Coombs test will be negative and in this Coombs test will be positive, the point I already told to you. So if you are getting a spherocyte with Coombs positive, then you are dealing with AIHA. Well, this is a classical thing, microspherocyte. You can see spherical shape RBCs, but their size is a little smaller than the usual spherocytes. How we diagnose a case of warm AIHA? Direct Coombs test showing autoantibody, usually IgG. This is a very important point to remember. And cold also, Coombs test will be positive. The point I already told you, whatever it is, any autoimmune, the Coombs test will be positive. But difference between the two, here it is IgM, here it is IgG, here it is IgM. Very, very important point to remember. Okay, they are usually not due to IgG. So warm due to G and the cold is due to M. What complication can occur in warm? There can be venous thromboembolism. In cold, there can be ischemia and peripheral gangrene. Very easy when this is happening. There is intense vasoconstriction and that can lead to gangrene also in extreme cases. Treatment in warm, you can use steroids, splenectomy for refractory cases, not for the routine cases. But cold, this is the best treatment, cold temperature. And I told you, the moment patient become warm, the problem disappears automatically. But very rarely we can use the rituximab and fludarabine, but only severe and refractory cases. Normally it is not needed. So by and large, in cold cases, you only have to rewarm the body to the normal body temperature. Now, patient, your question has finding consistent with hemolytic anemia, pallor, jaundice, splenomegaly, lab finding, reticulocyte count. That is the most important feature of hemolytic anemia. If retic count not increased, then it's not the case of hemolytic anemia. LDH raised, again a feature of hemolytic anemia. Total bilirubin, direct bilirubin is very low. Mainly indirect is feature of hemolytic anemia. Well, in our case, most likely due to AIHA point I discussed to you, Coombs test positive, there is no doubt. And now this is due to warm autoantibodies. The question now I'm going to discuss is from where the antibodies have come. How Coombs test became positive, that is the main point of interest at the moment. So we are getting autoantibodies against the RBC produced by amoxicillin. We just read about the causes of warm autoantibodies, penicillin and amoxicillin is the type of penicillin. So that can lead to Coombs test positive due to amoxicillin. This usually causes extravascular hemolytic anemia. So that's why haptoglobin level is normal. Level is normal. But sometimes in cold type, sometimes there can be intravascular hemolytic anemia, can be there, which is due to IgM mediated. But by and large, is mainly extravascular hemolytic anemia. So now in our patient, anemia is there, hematocrit is low, 20%. Indirect hyperbilirubinemia, normal haptoglobin level. You can see it is in the normal range. That means it's mainly extravascular hemolytic anemia. No, it's not intravascular. LDH level increase, that again indicate hemolytic anemia. All suggest extravascular hemolytic anemia. Her peripheral smear shows spherocyte without central pallor, and these findings are seen in AIHA and hereditary spherocytosis, the point I mentioned. But here in AIHA, family history is negative. Positive Coombs test. It's a very, and classically in our question it is written, there is no family history of blood disorder. But Coombs test positive. So in this we have a warm autoantibodies which can lead to autoimmune hemolytic anemia. Well, it's a simple question for you. We talked about Coombs test. Now I have a question for you. Write down the answer. What is Coombs test? Write down the answer. Answer is Coombs test, also known as antiglobulin testing, is a immunological lab procedure used to detect presence of antibodies against circulating RBCs, which can induce hemolysis. So I think it's a simple question. Now let's look into other options. First of all, is already in G6PD deficiency. Coombs test is negative, is a X-linked disorder. Okay, it occurs in males, but our patient is a female, so this is automatically ruled out. And moreover, in this Coombs test is never positive. Otherwise, is it triggered by medication, sulfa drug, infection, and fava beans? Okay, then in peripheral blood shows Bite cell and Heinz body. Well, I have one more question for you. Write down the answer. What is Heinz body? Well, they are inclusion within the RBC composed of denatured hemoglobin. It's a basic question. This is a classical thing, beautiful picture showing Heinz body. Hereditary spherocytosis is a strong family history. Why? Because it's autosomal dominant. But in our patient, there is no family history of blood disorder, rules out automatically. Positive osmotic fragility test is one of the most accurate tests to diagnose hereditary spherocytosis, what we write as HS. Negative Coombs test that automatically rules out HS. This is typical. This you can see spherocyte we can see, and they are fairly big size in contrast to the previous picture what we size, where we got micro spherocyte size was even smaller. Okay. Well, if you talk about option D, proximal nocturnal hemoglobinuria, what we write as PNH, is caused by defect in the cell membrane anchor that lead to complement mediated hemolysis. It's not antibody mediated, it's complement mediated. Episodic intravascular hemolysis and negative Coombs test, why is not a familial disorder. Evidence of venous thrombosis is very common in these patients. Well, now again I have two questions for you. Write down the answer. For the classical presentation of PNH and what the common site of venous thrombosis we just talked about, write down the answer. Well, the classical presentation of PNH is first morning urine sample is black or dark color. The rest whole day is normal. This is a classical feature, is the episodic phenomena. The common site of venous thrombosis in PNH is cerebral vein thrombosis. Okay. Well, option E, sickle cell anemia, is incorrect. Is again strong family history. As I discussed, there is no family history in our patient. And sickle shaped cell are seen in peripheral smear, not these spherocytes. Splenomegaly may be seen in childhood below 5 years, but by the above the age of 5 or 8 years, this autosplenectomy is there. So, but our patient is 25 years, splenomegaly is there. This automatically rules out sickle cell anemia. Well, golden line to remember, AIHA and hereditary spherocyte both can cause extravascular hemolytic anemia. A negative family history and a positive Coombs test is AIHA. A positive family history and negative Coombs test is hereditary spherocytosis, is total reverse. The peripheral smear in both conditions shows spherocyte without central pallor. And the last, the golden line, best line, if Coombs test is positive, then it is any autoimmune process. Like in this case, it's AIHA. There can never be any other possibility in all the 5 options other than autoimmune process. Well, I hope you liked the session. Just to inform you, we have following courses for you. Smart Medicine. There are 350 hours of pre-recorded video lecture of whole internal medicine. It includes all super specialty and allied subject, covering A to Z, including basic concept about every topic. Second, we have tests and discussion. There are more than 1,000 questions with discussion of the questions, sample question and discussion you saw in this session. Now, third thing is Medicine Simplified, which is a textbook of medicine. Harrison is the ultimate book to read medicine, but it is too vast. Reading 1 page of Harrison, you need half an hour. To understand, you need 2 hours, but you need only 2 minutes to forget what was written in that page. Then what is the solution? We have Medicine Simplified. It's a textbook of medicine, but so-called mini Harrison. It's a summary of what you need to read from Harrison. The book is available in Amazon also. Now, these 3 things are more than enough for your MD, DNB medicine and family medicine final exam preparation, NEET SS exam preparation. You don't need to read any other book. These 3 are complete in all the aspects. For more detail, you can contact at this number. It's for mobile as well as WhatsApp. And this is my personal email ID. Anybody want to reach to me, you can contact me at this email ID. Thank you very much.